Thank you, ma'am. Thank you, chairpersons. And at the outset, I would like to thank the organizers, MPICon, office bearers, and Thermo for the hospitality. Before moving on to the topic proper, I realized that almost every aspect of liquid biopsy was being covered in this conference, which has been so beautifully designed. So I thought, let me take a relevant area, which needs some attention in the form of liquid biopsy. And that's why it's titled Clinical Applications of Liquid Biopsy with special reference to pancreatic cancers. Now we know liquid biopsy is the buzzword. Recently in Nature Medicine, we have seen the cover page also being that of liquid biopsy. And its diverse applications we are seeing there is a paradigm shift. Just in a few years, we have seen the applications really expanding. And it's very important that we, as diagnosticians and researchers, understand this very important science. Please pardon me if some of these look very basic. This is for in the interest of postgraduates and the novice in this field. So the different applications, to make it very simple, as Dr. Monzan had very beautifully elaborated this morning, it is useful in screening, also to find out whether cancer is present. The traditional gold standard is, of course, tissue biopsy. But now with the liquid biopsies, we can also identify, type the organ, type the cancer, and of course the molecular alterations driving cancer, which might offer therapeutic targets, suitability of a potential treatment, identifying molecular residual disease, effectiveness of ongoing treatment, and also finding resistance mutations. It also helps when the cancer has metastasized, and we'll be discussing about temporal and spatial heterogeneity. So the different components of liquid biopsy are ctDNA, circulating tumor DNA, circulating tumor cells, circulating microRNA, extracellular vesicles, exosomes, tumor-educated platelets, and the list goes on. Researchers are all very excited about this field. So just in simple terms, circulating tumor DNA, these are small fragments of DNA found in the bloodstream, and these are secondary to apoptosis, secretion, and necrosis, as Dr. Patkar also had shown this morning. And circulating tumor cells are malignant cells that are shed into the circulation. So it might depend on the different type of organ and various factors. So the basic difference is tissue biopsy, as we know, is invasive. Non-invasive is liquid biopsy. And apart from the standard, that being gold standard and all, the sample that we sample that we take on a tissue biopsy might be just representing that particular location. Whereas in liquid biopsy, you kind of get a holistic picture. That's why it's called, it addresses spatial heterogeneity. Whether it is in primary or metastatic, it can pick up. If there is a difference in the same primary tumor, everything will be captured by the liquid biopsy. Specificity is lower, and that's still a limitation in liquid biopsy. But as the science, the technology evolves, we will see better specificity with liquid biopsies as well. Now, this is what I was talking about, tumor and temporal heterogeneity. So it gives a single snapshot of a particular tumor region. There have been guidelines, because this is becoming so important, and now standard of care, especially in lung cancers, ESMO has come out with guidelines as to how to report, how to manage these samples as far as ctDNA is concerned. We have different technologies which have been discussed at length this morning. The sample collection, again, for the benefit of the juniors here, Streck tube, if you have to preserve it for longer. EDTA, if you have an in-house lab which is going to process, you can as well collect it in EDTA. Streck tube or the Paxgen tube. These are the preservative tubes which can preserve your sample for longer, and there would not be degeneration. And most important aspect as far as processing is concerned, 2 steps of centrifugation is what is recommended, though guidelines do not say, but European Committee for Standardization, CEN, has come out with these 2 steps, 1900 G for 10 minutes and 16,000 G for 10 minutes at room temperature. So this is a very important step to process your ctDNA or liquid biopsy. Now, CHIP, again, Dr. Patkar had alluded to this morning. It's the age-related expansion of hematopoietic cells with somatic mutations. So this is one area where we need to be very, very much aware and cognizant of the fact that chip might be there, and we have to be conversant with this terminology. Now, addressing this would not be within the scope. So this also has been shown this morning. So just to reiterate, early stage disease, to improve the risk stratification as far as screening is concerned, capture tumor heterogeneity and genomic evolution, enhance the circulating tumor DNA guided adjuvant and palliative cancer therapy. I'll be talking a little bit more about this aspect. We know that the landmark article during the last ASCO and ESMO of ctDNA in the molecular residual disease, which has now created waves amongst the oncologists. They want this test. So we'll look at that as well. What are the, I think I will not go into depth of this molecular residual disease panels. Dr. Nikhil Patkar had spoken in the context of hematologic malignancies. As far as the solid tumors are concerned, there are two molecular residual disease panels. One is tumor informed. That is, you have a baseline sequencing of the tumor, and then you identify either 2 or 16, some assays take up 16, identify those and follow up during the course of treatment, monitor these. This is what is tumor informed. That is, you know that the tumor has this kind of sequence. And we know about clonal evolution. Cancer, it's not static, it is dynamic. It keeps changing over a period of time, and that is what liquid biopsy helps you with. When we call bespoke or tumor naive, that means you do not have any, you are not aware of what the tumor sequencing data is about. So you're directly going for a ctDNA panel. And that is what is tumor naive or tumor agnostic panel. This was the landmark Dr. Jean Tai's study, which had shown that after surgery in stage 2 and 3 colorectal cancers, the ctDNA, if it comes positive, the patient has high chances of recurrence and needs adjuvant chemotherapy, as opposed to a patient who does not have ctDNA in the blood following surgery. Generally, in their study, it was 2 weeks following surgery, and therefore they can do away with chemotherapy, which was very, very attractive to the patients and clinicians because they can avoid chemotherapy in this subset of patients. So this is there are several trials going on, one of which is the Circulate DNA trial, which also looks at the same thing. They had randomized colon cancer patients. I won't dwell much upon this in the interest of time. So moving on to circulating tumor DNA, our experience as far as pancreatic cancers is concerned. Pancreatic cancers is not a very well studied kind of group as far as liquid biopsy is concerned. The Atar group has been working on the circulating tumor cells, but we have a significant proportion of the circulating tumor DNA data also. So I thought let's do a retrospective audit over the last 1 year as to what is our NGS profiling of pancreatic cancers showing. So we have a solution which is a kind of multi-omic study which looks at both tissue and liquid biopsy, and we also do the longitudinal monitoring with CTCs. Study the chemosensitivity analysis and pharmacogenetic analysis. So it's kind of a holistic one. So this data gave me an opportunity to look at our liquid biopsy versus the tissue sequencing of the same patient. So this is the data. There were 300 patients. Females were 43% and males 57%. Now we did not have both for all the cases. Some of the cases had, this was not a trial, it was just those sequential patient data, which was patient samples which were coming in. So both were available only in 13% of these patients. Tissue sequencing for pancreatic cancers was done in 27% of patients. Only liquid biopsy was done in 60%. And mind you, all of these were either in the metastatic setting or at the time of progression. These were not therapy naive. So this was across the age groups, just to show you that this is decade wise. So first bar is 21 to 30, second one is 31 to 40. So if you could see that the commonest cohort was in the 61 to 70 age group. Excuse me. So this was the raw data. I'm sorry, did not have time to make some charts, but this is just to show you that the commonest on both ctDNA and the tissue sequencing was KRAS and TP53. So we know that earlier studies had shown that the predominant component is KRAS. So if you do a KRAS, If you don't get it, then go for a sequential testing of the rest. But this is what our data says, and it compares with the cosmic database, which shows that KRAS is seen in 53% as opposed to TP53, and then followed by the other mutations and fusions. This was a very small cohort which had matched tissue and circulating tumor DNA samples. And here, if you can see, the green ones show the mutations detected in both tissue and ctDNA. And the red ones are mutations detected in tissue alone. Blue is mutation detected in circulating tumor DNA. So if you can see that ctDNA is only a very, very small proportion. But if you look at the Excel, you can see that there is not, where it is 46% on ctDNA, on tissue it is 59%. So it is too small a number to compute sensitivity and specificity, but this is an ongoing study, so possibly we can have better results. This is the landscape of mutations that were seen in pancreatic cancers. The limitations of this data is that we had very limited number of matched samples, both tumor and liquid biopsy. Larger sample size is needed. Germline BRCA mutation was not known in majority of patients. Probably these were done in-house in those labs, or it was not done at all at that time. Possibly that awareness was not there. So this is only preliminary data, just to give you a hang of what is happening in this space. So this is by another group, Dr. Callison et al., which shows the landscape, and it resonates with what is seen by the other groups as well. So I would not talk about emergent. There's a lot of activity in this space. Emergent ctDNA alterations in one study showed that they were highly prevalent, associated with therapeutic actionability. So they say that since you're not doing a sequencing, you're missing out 14 to 20% of 27% of cases, which could have potential therapeutic targets. So at this point in time, what we know about mutation analysis in pancreatic cancers is that KRAS mutations constitute a significant chunk. It was thought 90%, but now it is seen that it is not as common, but it is very useful marker for MRD monitoring. Even if you don't have the facility of NGS, at least do a KRAS, that will give you a lot of information. Tumor agnostic indication for pembrolizumab in tumor TMB high or MSI high patients. Also, dabrafenib and trametinib in non-CRC patients with BRAF mutations or fusions. Liquid biopsy may also help detect pathogenic mutations or suspected deleterious BRCA1 alterations. And we know that germline BRCA mutations are indications for olaparib in the metastatic setting. So it's a tool to aid in early cancer detections, which Professor Dr. Monzan had spoken about. Refinement of blood tumor mutation burden within the context of MRD for monitoring of treatment response, and critically as a part of tools for diagnosis where biopsy is not feasible. I will not dwell much upon this. This morning, sir had spoken about pancreatic cancer MCD, but there's an immediate need to find highly sensitive methods for early detection because of the mortality associated with these advanced cancers, which are detected in a very advanced stage. So existing methods we know have low sensitivity specificity, and liquid biopsy probably would be giving the answer shortly. So at Datar, we work extensively on the circulating tumor cells, and I'll just give you a gist of what is happening in the true blood. So just for the information of everyone, three of our solutions, breast, glioma, and prostate, which are called by different names. These are CTC-based solutions, have got the US FDA breakthrough designation. True blood pancreas hasn't got yet, but this is what we are doing. We look at the CTC or CTC clusters, isolate them with negative enrichment process. Then we stain them like our routine immunohistochemistry with fluorescence-based immunocytochemistry, EpCAM positive, pancytokeratin positive, and CD45 negative status. And these are ICC profiled for pancreatic cancer, like we have standard mass spin, CK19, CA19.9, CK720, etc. Just to give a hang of whether, so this only detects the majority, that is a pancreatic adenocarcinoma. It doesn't look at other markers. Exosomes, there are several researchers who are working on exosomal RNA to identify, to help in the same process. So there is so much of buzz going on about pancreas. So a European consortium, Pancreatic, is now they have multiple sites recruiting individuals for identifying pancreatic cancer and picking it out early. Also, US-based organizations are looking at that, which Dr. Monzon would be able to tell us better. So in a summary, liquid biopsy is an adjunct, essential adjunct to tissue biopsy. It helps in screening and early detection, diagnosis and prognostication, help in minimal residual disease, molecular profiling for therapeutic targets, helps in longitudinal monitoring, identifying clonal evolution and resistance mutation. I thank our clinicians, our team, and our patients. Thank you so much.